Now we are passing on to our third session. I do like to invite our chairpersons, Dr. Lalmohan Banerjee, Dr. A.K. Banerjee, and Dr. S.B. Narogi. Thank you. This session has been sponsored by Medtronics, and topic is management of SS in heart failure. And this will be taken up by Dr. Shankhashubhra. Sir is an eminent physician and cardiologist, and I would like to request Dr. Das to come up and take up his session, sir.
Good morning, everyone. My sincere regards to all the organizers of South Kolkata IMA for giving me this opportunity to speak on the topic of heart failure, and my also sincere regards to Medtronic. So this topic is acute coronary syndrome and heart failure. So I think the commonest event that we encounter in our emergency department practice day by day is acute coronary syndrome with its various presentations. So if you see here that heart failure remains basically a clinical diagnosis. There is no single blood test or an imaging test or history or examination findings that really is a clincher in heart failure. It is more of an assortment of findings that gives you to come to a diagnosis of heart failure. Because when a patient comes to the emergency, then when you search for a gallop sound or when you see a raised JVP, it really gets difficult as the patient is panting and puffing, the patient is tachypneic, tachycardic. It really gets difficult to detect these subtle signs of heart failure. Now, heart failure is most commonly among the elderly above 70 years. Around 50% of these patients are females. Nearly half of these patients have heart failure with preserved ejection fraction. And there are lots of comorbidities, associated with heart failure. Except a few situations like if the heart failure is in the background of an acute MI, or if it is an accelerated hypertension leading to heart failure, then you can have an obvious diagnosis. Now, if you see the pathophysiology, there is a cardiac substrate. It may be a normal heart, or it could be a subclinical cardiac dysfunction. Maybe this patient had a asymptomatic LV dysfunction. Then comes the initiating triggers. So it could be an acute MI, it could be a myocarditis, it could be a poorly controlled hypertension, it could be an acute episode of atrial fibrillation, it could be some drugs, non-compliance with medicines, and so on. And then comes the amplifiers. We know about this reticular activating system, the renin-angiotensin-aldosterone system, the sympathetic nervous system, and other neurohormonal modulators that gets activated in patients of heart failure. The prime importance in heart failure is congestion. That is what we deal with. So there is left heart failure. So there is elevation of filling pressure of LV and LA. So there is LV distension. There is ischemia of the subendocardium of the LV. So more ischemia, more distension, and it gets like a vicious cycle for the heart. There is also a low output state which leads to tissue hypoxia as well. And this is how the vicious cycle continues. I think cardiorenal syndrome has been just discussed a little before, so we don't need to discuss it anymore. It's a complex interaction between the heart and the kidney in heart failure patients. So there are two categories. One is the de novo heart failure, a patient first landing up with acute heart failure. It could be an acute MI, it could be some arrhythmia, it could be a myocarditis, or it could be a patient of chronic heart failure who lands up with acute decompensation. So these are the two ways, either de novo heart failure or an acute decompensation. The triggers we have discussed: hypertension, ischemia, arrhythmias, infections, drugs. And there is a complex interaction of the various factors like myocardial dysfunction, endothelial dysfunction, neurohormonal activation. All these leads to the triggers. You can see in the slide, there is so many circles. So heart failure is a diverse condition. It's not only just simply it is an acute MI or it is an acute arrhythmia that lands up in the patient to heart failure. It could be an infection, It could be anemia, it could be a bad kidney, it could be a bad urinary tract infection, it could be a bad lungs. So all these can land up with fluid retention and heart failure, besides the normal cardiac findings, that is acute MI or other coronary related episodes. So to interpret easily how to approach a patient of heart failure in emergency, there has been a few axes. There is a 6-axis model by Braunwald. What is that? You see the blood pressure of the patient when he arrives, you see the heart rate, you see the precipitants, you see the comorbidities, you see the clinical severity, and whether it is a de novo or a chronic heart failure. So systolic blood pressure on arrival is very important. Better is the blood pressure, better is the prognosis for the patient. We have divided heart failure patients as hypertensive, normotensive, and hypotensive. So BP more than 140 or in between 140 to 100, prognosis is a bit better. These are called wet, warm patients. You can use diuretics, you can use vasodilators. On the other hand, if the patient is having a low blood pressure, systolic less than 90, we call it a wet and cold patient. So hypoperfusion. These are the patients who have a bad prognosis. Heart rate. Well, rate control is very important in patients of heart failure. But in those patients who have a very poor LV systolic function, the heart rate also contributes in LV stroke volume. So that is called permissive tachycardia. You have to allow a bit of heart rate to allow LV output. On the other hand, those patients who have a diastolic heart failure, that is heart failure with preserved ejection fraction, here rate control improves better, works better, because lesser is the heart rate, longer is the diastole, and better is the LV feeling. Besides, atrial fibrillation is one of the biggest precipitating factor concerning rhythm disorders in heart failure. So you need to decide whether you go for a rhythm control or a rate control. You need to decide whether the patient needs an electrical or a medical cardioversion depending upon the severity of heart failure. Discussed about these factors: precipitants, comorbidities, clinical severity, precipitants. Irrespective of all these other factors, the most important precipitant is either ischemia or infection. And if you discuss clinical severity, at one side it is acute LVF leading to pulmonary edema, and on the other side it is a cardiogenic shock or low output state. What are the factors you see in the emergency department? The alarm signs. Well, these patients need admission. So a low blood pressure, too much of tachy or too much of brady, electrical instability, a suspected acute MI, need for inotropes, the patient needs noradrenaline, dopamine or dobutamine, and need for invasive ventilation. So these are the high risk criteria. These patients need admission. Which are the patients who may be left, may be seen a little later? So normal serial troponins, systolic blood pressure reasonably more than 100 or 110, normal sodium, renal function is reasonably fine, maintaining good saturation in room air. So if these features are present, well, these patients, maybe you can see these patients after some hour in the triage. Phases of management. So I think this is the picture that we discussed a little later. So wet patient and cold patient. Wet patient means the patient will have a gallop, the patient will be orthopnic, the patient will have a positive raised JVP, a positive hepatojugular reflux, elevated JVP, ascites, fluid retention. And cold patient means there are features of hypoperfusion. So cool extremities, obtunded, hypotension, oliguria, pulsus paradoxus, alternance, and so on. So this is the algorithm of managing acute heart failure patients. Most of the patients are wet, that is, they are congested. There is retention of fluid, and few of the patients are dry, only 5%. So for the wet and warm patients, you have to see whether it is hypertension predominant or cardiac predominant. If it is an hypertensive LVF, then better you try with vasodilators first, then diuretics. And if it is predominantly a cardiac LVF, better we start with diuretics and then add a bit of vasodilators. On the other hand, if it is a cold patient, that is wet and cold, low blood pressure, systolic blood pressure less than 90, these are the patients with poor prognosis. You have to adjust the inotropes and the vasodilators according to the hemodynamic response. Then come the dry patients. The dry and warm, these are the best patients. You just need to adjust the oral drugs. And the dry and cold patients, these patients are normally dehydrated, so volume depleted patients, and you can give a bit of IV fluids to manage these patients. So far medical therapeutics are concerned, diuretics are the main therapy in acute heart failure, either bolus or infusion. Vasodilators are definitely there, nitrates. The inotropes are having a big role. Well, I think Dr. Paja discussed a bit. So you have to have a combination of noradrenaline with a bit of dobutamine. This is the best possible combination in acute heart failure patients. But if the patient does not maintain a reasonably good BP, then you have to think of adding other inotropes like dopamine or noradrenaline or epinephrine or others. But all these inotropes increase myocardial oxygen demand, and these are all proarrhythmic. Now coming to the other extent, cardiogenic shock. What is that? Persistent systolic blood pressure less than 90, or a fall of mean arterial pressure more than 30 millimeter of mercury with low cardiac index with an elevated filling pressure. That is cardiogenic shock. And you can see here that mortality is unacceptably high, more than 50%. Around 80% of cardiogenic shock is due to anterior wall MI, and there may be many conditions of mechanical complications of MI like VSD or free wall rupture or papillary muscle rupture that leads to cardiogenic shock. So 70% of ACS related cardiogenic shock is due to MI. There may be some other less common causes like acute myocarditis or a stress cardiomyopathy, or maybe an acute valvular regurgitation that leads to shock. Now, if you investigate patients of shock, there is not much of difference between acute LVF and shock patients, but echo assessment is important, the volume status. Will you give fluid to a shock patient? That depends upon the IVC assessment. So you see the diameter of the IVC, whether it is more than or less than 2.1 centimeter, and whether it is collapsible or not, more than 50% or less than 50% collapsibility. Accordingly, you have an idea of the right atrial pressure, whether it is less, normal or more, and accordingly you decide about fluid resuscitation. The other thing is NT-proBNP, whether the patient is congested or not. And BNP less than 100 or NT-proBNP less than 300, it almost excludes acute heart failure. On the other hand, if a BNP is more than 400 or a NT-proBNP more than 900 to 1800 according to the age group, it includes that definitely this patient has fluid retention. So this is the vicious cycle of patients, in cardiogenic shock that happens. Cardiogenic shock, initially we had an impression that it is a cardiac condition. It is actually not a cardiac condition. It is a multi-system condition. It is shock liver, it is shock lung, it is shock kidney, it is shock brain. So there are inflammatory mediators releasing from multiple organs, and ultimately it comes like an inflammatory state. So it is not only just we treat the heart. So that you have to understand when you manage cardiogenic shock. So definitively revascularization comes as a big role, whether it is a PCI or a CABG. But maintaining invasive ventilation whenever needed, maintaining inotropes to maintain the metabolic milieu comes as a big role. But the most important role now is the mechanical cardiac support devices that has come as a big role. So whenever an acute MI comes with cardiogenic shock, we try to stabilize the patient by invasive ventilation. Sometimes we put an IABP, intra-aortic balloon counterpulsation. So we put an IABP to improve the coronary perfusion. So here comes the role of the various mechanical support devices. For a long time, it was only IABP that was available in cath lab. But now, the newer mechanical circulatory devices like Impella or ECMO has come, and it has helped us in keeping these patients safe. This is a risk factor of patients in cardiogenic shock. So at risk, these are the prone patients A, B, C, D, E. This A and B are those patients who are at risk of cardiogenic shock. And your therapies, whatever you want to do, should be on A and B. Because once it goes to C, D, E, then whatever therapy you try, it's not helpful. So hit early and hit hard in cardiogenic shock patients. So these are some of the indications of IABP, cardiogenic shock, refractory angina, cardiac failure after a surgery. So this IBP balloon is placed in the descending thoracic aorta, and it dilates during diastole, and it deflates during systole. So it improves the coronary perfusion and thus relieves the coronary ischemia. So this was the concept of IBP for a long time, and this was the only mechanical circulatory device that was available to us. But now some newer cardiac mechanical circulatory devices have come that we will discuss. This is the inotropic part of cardiogenic shock. The same thing, the best one is the combination of noradrenaline with dobutamine, that is the best therapy. If it does not help, then you can go on with adding epinephrine or dopamine or the newer inodilators. There is a combination, this is called phosphodiesterase inhibitors, milrinone or levosimendan. These has also come, not going into the details of this. So this is important, suspicion of cardiogenic shock. So acute heart failure or acute MI, first of all you have to consider vasoactive therapy. So you see the hemodynamics and try to stabilize the hemodynamics with either a combination of vasoactive drugs like inotropes and vasodilators. Next, if this patient is in the category of A, B or C, you have to stabilize the patient, the shock patient. So you have to activate the shock team. The shock team arrives and decides about whether you will put an IBP or whether you will put an ECMO or whether you will put an impeller or what sort of mechanical circulatory device you will use. So if it is a non-coronary acute heart failure, IBP works better compared to an ischemic coronary heart failure. If it is an ischemic episode that leads to acute cardiogenic shock, it is better to put the patient to an ECMO or an impeller depending upon the availability of the devices and also the clinical situation. So now it has been said that ECMO should be a therapy that is very helpful in acute cardiogenic shock, and DOT to ECMO time should be less than the DOT to balloon time. I think you know DOT to balloon time. When a acute MI comes and we take the patient for a primary PCI, the DOT to balloon time should be less than 90 minutes. Now it has been said that when a cardiogenic shock comes, first of all you put the patient to an ECMO, that is DOT to ECMO time, you stabilize the patient, and then you take the patient for a primary PCI. So this is the classification, how you classify the various shock patients, and you decide that what sort of temporary mechanical circulatory support device can be used. I will just share my experience. So these are the various devices that has come. The left one is the IBP balloon in the descending thoracic aorta.
So you've got about 3 minutes left.
The middle one is basically it is the impeller. Impeller is basically a pump, that is a device kept in the left ventricle, and it ejects blood from the left ventricle to the aorta. So it is a pump, impeller. Next comes tandem heart. So tandem heart, it brings out blood from the left atrium and pumps the blood to the femoral artery. So it bypasses the LV. And last comes ECMO, extracorporeal membrane oxygenation, where you takes out blood from the venous system, the blood passes through the oxygenator and goes back to the arterial system. So these are various ways of supporting the circulation during phases of shock. Now this is a patient which came to our Apollo emergency a few days back. You can see the LV. It was just 20% LV. And I will show you the ECG. So this was the ECG, a patient with fast AF, atrial fibrillation. Now this patient had a coronary angiogram done 6 months back, which was normal. The history of the patient was acute shortness of breath for 2 to 3 days, orthopnea. When the patient landed up in emergency, BP was around 96/60, fast AF was going on, and echo was like this. You can see it. Hardly contracting LV, hardly contracting. EF is 20%. I think these are the subsets, the high-risk patients where ECMO or mechanical circulatory device really works. So these are the various views I can show you. The mitral valve hardly shows any contraction, hardly shows much movement. And this patient, we counsel the relatives, putting ECMO is really costly. It's really costly in any scenarios. But if it is put in early stage of cardiogenic shock, it really helps, especially the non-ischemic scenarios. If it is a myocarditis, this patient had an acute myocarditis that lead to this condition. So if it is a non-coronary state, or even if it is a coronary state, if you put this mechanical circulatory device early, then it really helps. And after 2 weeks, this is the echo finding. You can see it's really rewarding. Significant improvement in LV function after putting this patient to an ECMO support. So what I need to impress to you is that if it is initially, we had a very, non-rewarding feeling about cardiogenic shock patients. But if we really think about starting this mechanical circulatory support devices early in cardiogenic shock, it could be really a game changer, at least for 40 or 50% of patients, I think. So with this, I would conclude my discussion. Thank you.
Thank you, sir, for your brilliant presentation and upgrading our members with the recent advances of cardiac science. Thank you very much, sir. Sir is attached with Apollo Specialty Hospital, and this session was sponsored by Medtronics. Thank you, sir, once again. Now I would like to invite our eminent chairpersons to felicitate Dr. Dash.
One small question, sir. Does the myocarditis present in AF regularly or is